Good afternoon and welcome to Grand Rounds. Could most people get some lunch in the back and have a seat? Let's go ahead and get started. I'd like to take a couple of minutes to introduce Judy Blaine to you. Judy is an associate professor of medicine in the Division of Renal Diseases and Hypertension. Judy received her undergraduate degree from Harvard, graduated cum laude, and then we were fortunate to recruit her here to the MD PhD program where she became a physician scientist. She graduated from the MD program at CU AOA and did her research in the PhD program with Angie Ribera. Angie Ribera does work in channel regulation, and Judy studied potassium channels, both looking at the structure and function of potassium channels. We were again fortunate to continue to train Judy here, both as a house staff and as a fellow, and retain her on faculty in the renal division after her fellowship. Her career has focused on immune-mediated nephritis, and what she has studied is the podocyte in the kidney, how the podocyte is affected by immune complexes, and how that regulates protein flux, albumin flux in the kidney. I really look forward to her comments today on proteinuria and the underlying pathophysiology as well as therapeutic implications. So let's welcome Judy to the podium.
Can everyone hear me? Okay. So today I'm going to be talking about proteinuria, pathophysiology, treatment, and new approaches. I'd like to thank Dr. Schwartz for the very kind introduction. So just an overview of this talk. I'll start off with a case. Then I'll talk about how proteinuria occurs, how we measure proteinuria, what the clinical significance of proteinuria is, how we treat proteinuria using current treatments and some things that are in the pipeline. We'll look at whether proteinuria alters outcomes, treatment of proteinuria alters outcomes, and then there'll be some conclusions. So starting off with a case. So this is a 26-year-old female with type 1 diabetes who presents to established care. Her past medical history is only significant for type 1 diabetes. Her blood pressure is 126/82. Physical exam is otherwise unremarkable. Her creatinine is normal at 0.7 mg per deciliter, which gives her an estimated GFR of greater than 60 mL per minute. Her urine albumin to creatinine ratio is less than 30 milligrams per gram, which by today's standards is considered quote-unquote normal, and her urinalysis is bland. So starting this patient on an ACE inhibitor or an ARB now will A, either definitely slow development of albuminuria and renal disease progression, B, have no effect on albuminuria and renal disease progression, or C, it doesn't matter, all patients with diabetes should be on an ACE or an ARB. So who thinks A is correct? Anyone for B? Okay, and anyone for C? Okay. So a couple, it seems like a couple in each category. So we'll go during the talk, we'll go through the evidence and then come up with what the current evidence would recommend. But stepping back a little bit from the case and looking at how proteinuria actually occurs, so this is just a generalized overview of the kidney, and you can see that the blood flows in through the afferent artery, and then it gets filtered in the glomeruli, which we'll talk about in a little bit, and then eventually the ultrafiltrate becomes urine, which is collected in the renal pelvis and then goes out to the bladder. So each kidney contains about 1 million nephrons, and this is just a diagram of a single nephron. And you can see that blood comes in via the afferent arteriole, leaves via the efferent arteriole, And during that time, it passes through a tangle of capillaries lined with other cells, which are known as the glomerulus. And anything larger than about the size of albumin is retained in the blood. Anything smaller than that is filtered out, goes into Bowman's base, and then ultimately down into the proximal tubule, where it's manipulated further in the rest of the tubular sections to become the final urine. So the glomerulus really is key for discriminating on which size particles get through, which get filtered, and which don't. And this is just a structure of a glomerulus, so that, again, this is honing in on a small segment of that tangle of capillaries. And you can see that blood comes in via the afferent arteriole, it leaves via the efferent arteriole, and then these glomerular capillaries are lined by these cells called podocytes, which in this diagram are orange, and they really wrap the capillaries very, very tightly. And these cells, the podocytes, and they are part of something called the glomerular filtration barrier, which is absolutely key for discriminating based on size in terms of what gets filtered and what doesn't, particularly in terms of protein selectivity. So this diagram here is it's a transmission electron micrograph of a podocyte, and this is the podocyte. As you can see from the scanning electron micrograph, is a cell with a huge cell body, and then processes that ramify off the cell body divide down to become smaller and smaller and smaller until ultimately they become these foot processes which are linked to one another via a slit diaphragm. And the foot processes interdigitate with neighboring podocytes. So it's like a zipper-like arrangement. So the foot processes from one podocyte will contact the foot processes from another podocyte. And the filtration of large proteins is essentially prevented by this glomerular basement membrane and this filtration barrier made up of the podocyte foot processes and the slit diaphragm. So the traditional view of podocytes, and this is what I was taught in medical school, is that the podocytes normally are sort of stationary cells. This is the endothelial side, the blood side. This is the podocyte side. Blood comes through here. There's a lot of filtration pressure. And what prevents proteins larger than about the size of albumin from getting filtered is this slit diaphragm. So when you have massive albuminuria, the slit diaphragm somehow gets disrupted or removed, and then you just have a lot of protein sort of essentially bypassing the podocytes. However, work from our lab and others has shown that this is not necessarily the case. So podocytes definitely can take up albumin. We have shown this in vitro and in vivo. So this is in vitro cultured podocytes loaded with FTSE albumin, which fluoresces green upon excitation. And you can see that at 37 degrees, which promotes endocytosis, the podocytes take up albumin. There's little uptake at 4 degrees. You can quantitate this. And then you can do something called an albumin overload model, where you raise the serum albumin in mice, you essentially double it. And when you do that, you start actually getting filtration of albumin through the podocytes, and you can actually see albumin, which is red here, in a podocyte. This green is a podocyte marker, and the blue is nuclei. So you can actually see albumin vesicles in podocytes. We and others have developed some techniques to actually try to look at albumin trafficking or protein trafficking in the kidney in real time. So we're using something called intravital imaging, in which we can take a live mouse, expose the kidney, and use a confocal microscope to actually look at what happens when you inject fluorescently labeled albumin. And this movie won't play from the presentation, so I'm going to try to play it separately. So as you can, so this is just an image of an actual kidney in a live mouse, and the blue is a dye that we inject to light up the nuclei. The initial green is just autofluorescence, and then we can actually inject FTSE albumin. And I don't know if you can see it, but you could see little bunches of albumin collecting under the blue nuclei of the proximal tubules. So we can actually look at albumin trafficking in real time. We can actually get views of the glomerulus. So this is a mouse that was injected with FTSE albumin, which is green, and then also Texas red dextran of a large size, which will just stay within the blood vessels. And the tangle of red are the glomerular capillaries, the green is the albumin, and the yellow is where they co-localize. So we can actually start to track albumin particles within the glomerulus and try to get a sense of albumin trafficking in real time. But as you can see from the movie I just showed you, the tubules also take up filtered proteins. So when you think about the development of albuminuria, it's definitely the glomerulus plays a very, very big role, but the tubules, especially the proximal tubules, also do. And so if you have tubular dysfunction, that can also increase albuminuria or proteinuria. And that's just something to keep in mind. We see it sometimes in septic patients who develop this very transient sort of mild albuminuria, and that's often due to tubular dysfunction if they have something like ATN. So basically what I've described so far is that the major barrier to filtration of proteins the size of albumin or larger is the glomerular filtration barrier. So this structure is really key. Small proteins, less than 70 kilodaltons inside, are freely filtered, and then they're often reabsorbed by proximal tubule cells. But significant albuminuria always involves damage to the glomerular filtration barrier. So how do we measure proteinuria? So there are a number of different tests, and I'd like to go through them in some detail, because sometimes it can be confusing. So the most common, widely used, simplest method to measure proteinuria is urinalysis. The advantages are that it's cheap, it's easy to do, it can be done routinely in a doctor's office. The disadvantages are that it's semi-quantitative. It's specific, but it's not that sensitive. So the lower limit of detection is 10 to 20 mg per deciliter, which if you're making about 2 liters of urine a day is about 400 milligrams of protein. It only measures negatively charged protein. So really, the major protein that it's going to detect is albumin. It's not going to detect positively charged proteins like light chains. False positives can occur with very alkaline urine with a pH of greater than 8, with gross hematuria after use of contrast and certain antiseptics. So that's something to keep in mind if your patient has just had one of those tests involving those things. There's another test that we really don't use very much anymore. It's a sulfosalicylic acid test. It detects all urinary proteins. The lower limit of detection is 5 to 10 mg per deciliter, but the disadvantage of this test, again, is it's not quantitative very much at all, and you need to have sulfosalicylic acid on hand. So more quantitative methods, there's a spot or random urine albumin or protein. And what you absolutely have to do this test is a concurrent urine creatinine, because that accounts for differences in urine concentration. A first morning void is best, and the daily albumin or protein excretion is calculated by dividing the urinary albumin or protein by the urinary creatinine. So sometimes we'll get people referred to us in clinic, and the referral will say proteinuria, but all there'll be is a urinary albumin or a urinary protein without any urinary creatinine. And it's really impossible at that point to gauge the level of proteinuria. The reason this works, so for instance, if you get a urinary protein of 100 and a urinary creatinine of 50, that would suggest that the person's excreting about 2 grams of protein a day. And the reason this works is that if you assume that everyone excretes about 1 gram of creatinine a day, the units will work themselves out so that you can just take the urine protein divided by the urine creatinine from the spot sample and get the average daily excretion of protein. This assumption is obviously not true. So creatinine is dependent, your creatinine excretion is dependent on how much muscle mass you have. And obviously, the creatinine excretion in a small woman is going to be very different to the creatinine excretion in a large man. But as a general rule of thumb, it works pretty well, and it's a very convenient and easy way for us to check protein excretion in the clinic. So the quote-unquote gold standard of urinary protein detection is the 24-hour urine protein. Somebody collects their urine for 24 hours, and then you just measure the total amount of protein. In this case, it's important to obtain creatinine as a quality control measure. So in this case, you don't take the total urinary protein and divide it by the urinary creatinine. You just look at what the total urinary protein excretion is that the lab will report to you in 24 hours. But the reason we like to get a creatinine is because it tells you how well the urine collection was done. So we know that men should excrete 20 to 25 milligrams per kilogram of creatinine a day. We know that women excrete about 15 to 20. So if you take 20 as the average, so if your patient weighed 100 kilograms, you'd know they should excrete about 2,000 milligrams of creatinine a day. So if this person turned in a 24 urine collection and the urine creatinine was only 600 milligrams, you'd know it was a way under collection. Or if it was 4 grams, 4,000 milligrams, you would know it was a way over collection. So it gives you an idea of how good the 24-hour urine collection was. So the drawbacks to the 24-hour urine protein is that it's cumbersome to collect. Often patients say they will do it, but then they never return it. So there's some drawbacks to obtaining it, but it is a good measure of urinary protein. So a question is, how well does the spot urine protein to creatinine ratio correlate with the 24-hour urine? And these are data from a very old study done in 1983, which took people and actually just measured their spot urine protein to creatinine ratios and their 24-hour urine proteins and then plotted them out. So the line of identity would be where they perfectly correlate, and then deviations from lines where they don't correlate that well. And what you can see is that somewhere between very low levels and up to about 6 grams, the correlation between the spot and the 24-hour urine is pretty good. Beyond that, it really isn't. So if you have somebody who you think is excreting 10 grams of protein in their urine, then you really do need to get a 24-hour urine to confirm that. So what are normal, abnormal levels of albuminuria? So currently, excretion of abnormal amounts of albumin in the urine is defined as excretion of greater than 30 milligrams of albumin a day. By this definition, about 10 to 15% of the U.S. adult population is albuminuric. And you can further break, there's the albuminuric category, and then you can look at lower levels, something that used to be called microalbuminuria, which is excretion of between 30 to 299 milligrams of albumin a day. Now it's called moderately increased albuminuria. And then there's overt albuminuria, which is now called severely increased albuminuria, which is excretion of greater than 300 milligrams of albumin a day. And this categorization is really used a lot in studies, especially studies in diabetics, where people are looking at progression from normal albuminuria, which is defined as less than 30 milligrams a day, to moderately increased albuminuria or severely increased albuminuria. So if a patient presents to you with albuminuria, does that mean anything? Or is it just a finding that you see? So what are the clinical consequences? Is albuminuria or proteinuria bad? So data from many, many studies, I'm just showing you one, has shown that albuminuria associates with a variety of bad things, including all-cause mortality. So this is from the Chronic Kidney Disease Prognosis Consortium. It involves 1.6 million patients from all parts of the world. And you can see that even at what, quote-unquote, a normal GFR, so GFR between 90 to 105, once you start developing moderately increased albuminuria, so albuminuria of somewhere between 30 and 299 milligrams a day, you have a significantly increased risk for all-cause mortality, and that goes up as you become more albuminuric. And as you can see, as the GFR drops, these risks become even more pronounced. And albuminuria also associates with progressive kidney disease. So again, you can see that even in people with quote-unquote normal GFRs, as you become overtly albuminuric, you have an increased risk for progressive chronic kidney disease and a significantly increased risk of actually developing end-stage renal disease. And again, this is just one cohort I'm showing you, but this has been confirmed in multiple other studies. People have tried to look at the mechanisms for this. We've done some work showing that if you expose podocytes to albumin, it increases pro-inflammatory cytokines. People have found some of the things in the proximal tubule as well. Because of this marked association between albuminuria and progression of kidney disease or development of end-stage kidney disease, the National Kidney Foundation and international kidney organizations have actually recommended adding addition of albuminuria to the staging of kidney disease. So this table here goes through the traditional stages of kidney disease divided by GFR, and then you can also look at the person's level of albuminuria. So A1 would be quote-unquote normal or less than 30 milligrams per gram. A2 would be moderately increased or 30 to 300, and A3 would be overt albuminuria. So you could have somebody who's a stage 2 A1 or a stage 4 A3. So proteinuria seems to be associated with bad outcomes. I mean, there still is debate as to whether it's a surrogate marker or an actual mediator. But regardless, because it's associated with worse outcomes, there's been a lot of interest in treating and reducing proteinuria. So the mainstay for a long time has been RAS inhibition, so inhibition of the angiotensin system. And I'll show you lots of trials involving that, but just to briefly review how this works. So angiotensinogen is made in the liver. It's cleaved by renin, which is made in the kidneys, to angiotensin 1, which is further cleaved by angiotensin-converting enzymes in the pulmonary vasculature, but also in circulation. So ACE inhibitors work at that step. So cleavage of angiotensin 1 results in production of angiotensin 2, which acts on the angiotensin 1 receptor to cause bad things like vasoconstriction and aldosterone secretion. And angiotensin receptor blockers work by blocking the angiotensin 1 receptor. So ACEs and ARBs are by far the most widely used agents to reduce proteinuria. They have proven efficacy, as I'll show you, in albuminuric diabetic kidney disease and in non-diabetic proteinuric kidney disease with an estimated GFR of less than 45. Some other agents, so aldosterone antagonists. So they actually block the effects of aldosterone, which is produced after activation of the renin-angiotensin system. So they're never used as first-line agents to reduce proteinuria. They do result in a significant decrease in blood pressure and proteinuria when added to ACEs or ARBs in those with mild to moderate CKD. At this point, we don't know their effect on the risk of progressing to end-stage renal disease, and they have significant drawbacks in that they can cause hyperkalemia and gynecomastia. Direct renin inhibitors, so if you remember, renin was that key first step that's blocking the pathway really high up. So the one that's approved for use in the United States is aliskiren. This is the AVOID trial. It was a multinational trial involving 599 patients with diabetes, hypertension, and proteinuria. They received aliskiren or placebo in addition to max dose losartan, and the primary endpoint was looking at a reduction in the urine albumin to creatinine ratio. And as you can see, the people on aliskiren had a significant reduction in their urine albumin excretion. The adverse events were similar in the two groups. So this looked pretty promising, which then led to the Altitude trial, which is a much larger trial involving 8,561 patients with diabetes and CKD on either an ACE or an ARB. They were treated with aliskiren or placebo, and the primary endpoint was a huge composite, time to cardiovascular death or first occurrence of cardiac events, a stroke, ESRD, need for dialysis, or doubling of serum creatinine. But this trial was actually stopped early because there was no evidence of benefit, and there was a non-significantly higher rate of stroke and hypertension in the aliskiren group. And not surprisingly, the aliskiren group also had a higher rate of hyperkalemia. And this trial really significantly dampened our enthusiasm for using direct renin inhibitors. Calcium channel blockers have been used, so both diltiazem and verapamil decrease proteinuria by about 30% in proteinuric diabetics and non-diabetics, so you don't get as much bang for your buck as you do with ACEs or ARBs. Dihydropiridine calcium channel blockers like amlodipine are significantly less effective and are not widely used for the sole purpose of reducing proteinuria. Some new developments. So there's a group of relatively new, I suppose, drugs called endothelin receptor antagonists. And the way this pathway works is that things like growth factors, cytokines, angiotensin 2, hypoxia, or stress can act on endothelial cells to make them produce endothelin 1. Endothelin 1 acts on smooth muscle cells primarily by the endothelin type A receptor to cause calcium release within the smooth muscle cell, which causes vasoconstriction, cell proliferation, and inflammation. So previously, small studies had shown a significant reduction in proteinuria in patients treated with short-term with endothelin receptor antagonists, but some of these trials were limited by significant side effects, including volume overload and heart failure. So the ASCEND trial basically was a much bigger trial looking at close to 1,400 patients with type 2 diabetes and moderately increased albuminuria, and they were treated with avasentan, which is a selective ETA receptor antagonist, but also blocks the ETB receptor to a certain extent. All patients received ACEs or ARBs. These patients had fairly significant renal dysfunction. The mean serum creatinine was around 2, and the mean albumin excretion was about 1.7 grams a day. And the primary outcome was a composite of time to the doubling of serum creatinine, end-stage renal disease, or death. And one thing you might notice here is that the follow-up only goes to 6 months. And the reason for that is the trial was terminated early because of a very significant increase in heart failure and volume overload in people treated with avasentan. But even up to that time, there was no significant difference in the primary outcome. And there also happened to be a trend towards increased mortality in the avasentan group. One thing that a sub-analysis showed is that avasentan treatment did result in a significant decrease in the albumin to creatinine ratio compared to placebo by 3 months. And if you remember that avasentan it blocked the ETA receptor, but also had some effects on blocking the ETB receptor. And in certain vasculature, ETB is actually good because it provides vasodilation. So the thought was that possibly by having a less specific ETA receptor antagonist, this wasn't the best idea. And so there's actually a big trial now called the SONAR trial looking at a very specific endothelin receptor A antagonist in reducing proteinuria in diabetics. But results of the trial is still ongoing, so the results aren't known yet. And then endothelin receptor antagonists are also being used in different kinds of proteinuria kidney disease. This is very recent results from the DUET study, which is a trial of patients with FSGS who were randomized to sparsentan, which is an ETA receptor antagonist plus an ARB, versus a max dose irbesartan. And preliminary results show a very promising decrease in proteinuria. And sparsentan in this case appeared safe and well tolerated. But the entry inclusion for this trial was very, very strict. So the patients had to have a completely normal echo and a completely normal BNP before they were allowed into the trial. SGLT2 inhibitors are another thing that may be used to decrease proteinuria in diabetic patients. So the EMPA-REG outcome trial is a trial of over 7,000 patients with type 2 diabetes. The patients most of them had early diabetic nephropathy. So most of them had a well-preserved GFR, and most of them had albumin creatinine ratios of less than or equal to 300 milligrams. Most of them were also treated with ACEs or ARBs. The primary outcome was primarily a cardiovascular outcome. The secondary outcome was a renal outcome. And you can see here that there was a significant benefit to patients in terms of having a worsening nephropathy in those treated with empagliflozin. So this might be something else that we add to our arsenal of treatment for type 2 diabetics. So we have several agents to reduce proteinuria, but does treatment of proteinuria actually alter outcomes? So to really look at this, you have to divide patients into diabetics and non-diabetics. The trials in diabetics, so the landmark study which really started this whole field was the Captopril trial, which was published in 1993. It was a double-blind, multi-center trial of 409 patients with insulin-dependent diabetes. They were randomized to placebo or Captopril. The mean serum creatinine was 1.3 mg per deciliter, so the renal dysfunction was fairly mild in terms of creatinine, but they had significant proteinuria. They had 25 urine proteins between 2.5 and 3 grams a day, and about 75% of the patients had hypertension. And the results are pretty dramatic. So you can see that with 4 years of follow-up, there's really a very significant decrease in the patients treated with Captopril in terms of doubling of serum creatinine. And if you look at those patients who died, needed dialysis or transplantation, the rate is halved in the Captopril group. So very, very significant. Since then, there have been multiple other trials. I'm not going to go through all of them. I'm just going to show you a Cochrane database review of what they consider to be the best trials. So if you look at ACEs versus placebo and doubling of creatinine in hypertensive diabetics, this is trials. There are about 3,400 patients in each group, and you can see that there's a benefit to being on an ACE. Also benefit to being on an ACE in terms of preventing development of end-stage renal disease. Similar thing with ARBs, so ARBs, again, beneficial in terms of preventing doubling of creatinine and also developing end-stage renal disease. Just to note that trials with ARBs all involve just type 2 diabetics, whereas the trials with ACEs involve both type 1 and type 2 diabetics. So the magnitude of risk reduction, various trials have shown that for diabetics, for every 50% reduction in proteinuria or albuminuria, the risk of kidney disease progression, including progression to end-stage renal disease, which is obviously a very hard endpoint, falls by about 35 to 50%. And for non-diabetics, the risk reduction appears similar, the caveat being that the GFR has to be less than about 45, and I'll show some data to support that. So what about primary prevention? So we have somebody who's diabetic, but they have a normal creatinine, and they have normal blood pressure, and they don't have albuminuria. So should we be treating these people with ACEs or ARBs? So the DIRECT Renal Pool 3 was a trial which took combined results from a bunch of trials involving patients with type 1 and type 2. There were more patients with type 1. The patients were all normal albuminuric at baseline. All the type 1s were normotensive, and about over half of the type 2s had well-controlled blood pressures. And you can see that in those treated with candesartan or placebo, there was really no difference in the development of moderately increased albuminuria. So that's some hint that definitely in type 1s, this may not be, primary prevention with an ACE or an ARB may not be beneficial. The best trial really is the RAS trial, which was a randomized double-blind placebo-controlled trial with 285 normotensive, normal albuminuric type 1 diabetics. The patients received enalapril, rosartan, or placebo. This was a very well-done trial in terms of they biopsied every single patient, and then 5 years later they biopsied them again, and the majority of patients actually completed the 5-year follow-up biopsy. So secondary endpoints were changes in GFR and changes in albuminuria. One of the primary endpoints they looked at was that changes on kidney biopsy, and they found that treatment with an ACE or an ARB didn't change mesangial volume or any other morphologic feature on kidney biopsy in treated versus placebo. So directly looking at the tissue, there didn't seem to be any direct benefit of treating people with an ACE or an ARB. And this is just the data on development of microalbuminuria, and you can see that there's no difference in the placebo versus the enalapril groups, and for some reason, it's not explained well, there seems to be an increase in the losartan treated group. So for type 2 diabetics, for normotensive, normal albuminuric type 2 diabetics, the jury is still out on sort of whether primary prevention is with an ACE or an ARB is beneficial. For hypertensive, there's actually a fair amount of evidence that that prevention with starting these patients on an ACE or an ARB, even if they have normal albuminuria, is good. The biggest or the best done trial is the RoadMap trial, which involves over 4,000 patients with type 2 diabetes treated with olmesartan or placebo. These patients actually, even at baseline, had pretty well-controlled blood pressures. The mean blood pressure was like 136/82. The primary outcome was time to onset of moderately increased albuminuria. And you can see that the olmesartan group had a significant reduction in the proportion of patients becoming microalbuminuric from having what we consider normal no really normal levels of albumin excretion to becoming microalbuminuric. Just a caveat, the number of deaths from cardiovascular causes was higher in the olmesartan group, but that group also had a higher number of patients with pre-existing coronary artery disease. The FDA has actually investigated this and found that olmesartan does not appear to be directly related to an increased risk of causing cardiovascular events. So trials in non-diabetic patients. So some of these are relatively older trials. This is the APRI trial. There's 583 mostly non-diabetic patients. They had fairly significant renal dysfunction, creatinines between 1.5 and 4, and a lot of proteinuria. The average proteinuria was 1.8 grams a day. 80% of the patients had hypertension, and the primary outcome was doubling of creatinine or need for dialysis. And you can see that this is the patients not reaching endpoint. So the high line is better, and these are the benazepril pre-treated patients did better than the patients who were on placebo. If you adjust for diastolic blood pressure, and then you actually stratify by segments of proteinuria, you can actually see that the risk reduction is only significant in those who actually were excreting more than 3 grams of protein a day. Because in the other two cases, the 95% confidence intervals cross 1. So subsequent to that, the RAIN trial was published as a randomized, double-blind, placebo-controlled trial of 166 non-diabetic patients. Again, they all had fairly significant renal dysfunction. Mean creatinine was around 2.4. They had a lot of proteinuria. The mean proteinuria is around 5.3. They were randomized to ramipril or placebo plus other drugs to control hypertension. They went for equivalent blood pressure control. The primary outcome was a measured GFR. Secondary outcome was a large composite of changes in proteinuria and progression to end-stage renal disease and cardiovascular events. And just looking at the kidney survival, you can see again the higher line is better. So these are percent of patients without the endpoint, and the patients who were treated with the ACE inhibitor had higher rates of kidney survival. Again, if you look at this in a little bit more detail, so this is data from the RAIN cohort, and it's stratified by proteinuria. So you can see that the patients treated with proteinuria had very steady level of GFR. They didn't have much GFR decline, whereas patients who were treated with placebo had a significant GFR decline. And the worse the baseline proteinuria, the higher the GFR decline, and those same findings held true for development of that combined endpoint, which involved cardiovascular events, changes in proteinuria, and development of end-stage renal disease. This is again trying to bunch of trials together and look at non-diabetic patients. So this is a study of studies looking at over 1,000 non-diabetic patients. ACE was compared to placebo in 5 studies, or another blood pressure med in 5 studies, and unspecified med in 1. The blood pressure was controlled to less than 140. In all the studies. And what you can see from this trial is that the patients who were on the ACE had a significant decrease in their blood pressures, as you would expect, as well as a significant decrease in their urinary protein excretion, which you would also expect. When you adjusted for blood pressure and proteinuria, there was a significant decrease in survival without end-stage renal disease in patients on an ACE, as well as if you combined patients who double their creatinine and developed end-stage renal disease. So ACEs definitely appeared to be protective. And again, if you look at this by levels of proteinuria, so 1 is no difference between ACE and placebo, and then this is increasing magnitude of risk reduction. And you can see patients with the highest starting levels of proteinuria had the biggest reduction in their risk of developing end-stage renal disease. So the RAIN study, actually, those authors went back and looked more closely at their patients, and they looked at patients, so most of the RAIN patients had very significant proteinuria. So then they actually looked at patients with subnephrotic proteinuria. So they looked at about 186 patients in their cohort. They still had significant renal dysfunction in terms of creatinine. Their creatinine was 1.9 mg per deciliter, but their proteinuria was all between 1 and 3 grams a day, so less than nephrotic. Again, they were randomized to ramipril or placebo. They tried to achieve equivalent blood pressure control. The primary endpoint was change in GFR and time to end-stage renal disease. And what they found was when they divided patients up by GFR, so patients with a starting GFR of less than 45, in those patients, ramipril appeared to be protective. So this is patients without end-stage renal disease, and there's a higher number in the ramipril group. However, in patients with a GFR of greater than 45, there appeared to be no benefit. You'll notice that the numbers don't add up to 186. They don't really talk about what happened to the patients for whom there was no data. Some of them, they said there was no follow-up GFRs, but they don't account for all of the patients. And finally, the ASK trial. So this was a large trial in hypertensive African Americans with CKD. They were randomized to a very strict blood pressure goal, less strict blood pressure goal. They, again, have fairly significant renal dysfunction in terms of creatinines. Baseline creatinines were somewhere between 1.7 and 2.2. They excreted very little proteinuria. However, the proteinuria was well less than a gram in most patients. And the primary outcome was rate of change of GFR or composite of reduction of GFR by more than 50% from baseline, ESRD, or death. So, again, pretty hard outcomes. And the results are interesting. So if you stratify patients in terms of people who really had very, very little proteinuria, then actually treatment with ramipril appears to be slightly worse, actually, because patients on metoprolol appear to have done the best. But if you look at patients with more proteinuria, then ramipril is the most protective. Just a caveat, there was a very recent paper that came out in JASN, which found that the urine samples for the ASK trial were stored in acetic acid, using acetic acid as a preservative, and acetic acid degrades protein and albumin. And so these results may not be entirely valid because there was a lot of degradation, I think, of the protein in the samples, in the urine samples. But again, looking at results from the ASK trial, again, these are people with pretty significant renal dysfunction in terms of creatinine. So the bigger the reduction you can achieve in proteinuria, the more you lower the risk for end-stage renal disease. So again, that definitely seems to hold true in patients with significant renal dysfunction at baseline. So what about RAS inhibition for early non-diabetic CKD? So these are people with relatively well-preserved GFRs with not much proteinuria. So this is best looked at in a meta-analysis. There were 4 studies. 2 of the 4 reported either progression to end-stage renal disease or doubling of creatinine. 1 study showed no significant difference in progression to ESRD in those with a GFR of greater than 45. The other study showed a significant reduction in the doubling of serum creatinine. And based on all this evidence, there's really insufficient evidence at this point to conclude that an ACE or an ARB decreases the risk of kidney progression in early non-diabetics. So people with very, very early stages of kidney disease that are not diabetic. So back to the case. Based on all the evidence I've shown you, particularly the evidence for primary prevention for type 1 diabetics, at this point, as our knowledge currently stands, based on the trials that have been done, starting this patient on an ACE or an ARB will have no effect on the development of albuminuria and renal disease progression. But the patient should be screened every 6 to 12 months for development of moderately increased albuminuria, because at that point it definitely would be appropriate to start an ACE or an ARB if the patient can tolerate it. So in conclusion, even low levels of proteinuria or albuminuria are associated with kidney disease progression and an increased risk of mortality. Again, the jury is still out on whether proteinuria or albuminuria is just a marker of something bad going on or actually a mediator of something bad going on. Significant albuminuria always involves damage to the glomerular filtration barrier. There's very good evidence to suggest or to say that diabetic patients with an albumin excretion of greater than 30 milligrams a day should be treated with some form of RAS inhibition, providing they can tolerate it. For non-diabetic patients with proteinuria greater than a gram a day and significant kidney dysfunction in terms of GFR, those patients should be treated with an ACE or an ARB. Some of the people who did the work that I showed you in the sort of more basic science part of the talk, Dr. Dobrinsk did the intravital imaging, helped assisted by Linda Lewis, and then the cytokine expression was done by Kaio Okamura. And I'd be happy to take any questions.
Very much, Judy. That's a good question from the students and
The one question I do have was on one of the all-cause mortality slides. It showed kind of, I don't know, a parabolic curve where even with a high GFR, it seemed to have worse outcomes than a moderate or medium GFR. I'm wondering if that was just not enough data set or if you can comment on that.
So was that in a particular study or?
It was on one of the grids that you showed initially. I'm not sure which study it was, but in looking at all-cause mortality, estimated GFR, and then the amount of proteinuria, kind of that 6x6 or 4x4, it showed that all-cause mortality was actually worse with a higher GFR, the highest level GFR than the next two down. I don't know if you can comment on that.
Oh, okay. So we think of the higher the GFR, the better, but actually hyperfiltration is bad. So hyperfiltration is another indication of kidney damage. So it's quite possible that people with supernormal GFRs, either having early diabetic nephropathy, which can cause hyperfiltration, or some other kind of stress that's causing hyperfiltration that's bad.
Nice talk. As a transplant physician, I had a couple questions. Is there any good data in calcineurin inhibitor-induced kidney disease that we see all the time, and we often see proteinuria with it, that there's actually a benefit, probably not in survival because our patients don't live that long, but in terms of progression to worsening renal dysfunction? And then the second part, which is very similar, is in mTOR inhibitors, which we know can actually lead to proteinuria. Is there any benefit in treating those patients with an ACE inhibitor or an ARB and leaving them on the mTOR inhibition, since that may be beneficial for their graft, or is it best to just stop that drug?
So those are really good questions. I think what we've done for most proteinuria kidney disease is sort of extrapolate from the diabetic studies because we just have so much data in diabetic patients, and saying basically that the lower the level of proteinuria, the better. But there are no really good studies proving that, especially in non-diabetic patients. Sort of my gut feeling as a nephrologist is if somebody has proteinuria and we know that it's a marker of something bad, if there's a medication causing that and it can be stopped, we often will try to stop it. If it can't, then we will often add on an ACE or an ARB if the patient can tolerate it to reduce proteinuria. Again, extrapolating from the diabetic literature where there is good evidence for that. But there's no great trials showing it one way or the other.
Yeah, that's what we do. I just wanted to make sure
Right.
that wasn't being saying you don't need to do that because it doesn't work.
What about for the various conditions that cause acute renal failure? Is there any utility for measurements or predictive or prognostic or pathophysiologic implications of proteinuria in those settings? ATN, interstitial nephritis, acute GN.
So I don't know of studies which have really looked at somebody who has transient proteinuria, whether it's beneficial at that point to put them on an ACE or an ARB. And obviously, if they have AKI, the last thing we're going to recommend is to start an ACE or an ARB because that'll further reduce the GFR. There's more data coming out saying that even if you have a bout of AKI or a bout of renal dysfunction, that you're more inclined to develop CKD. But I don't think really people have looked at what happens if you have a bout of AKI and you try to do something, a maneuver to specifically protect the kidney, whether that's beneficial or not. And again, a lot of our tools, the tools that we use are going to be contraindicated in somebody with renal dysfunction.
Judy, thanks for the talk. I may have missed this, but about 15 slides in, you had a slide about the using diltiazem versus dihydropyridines. And our current algorithm is probably based on hypertension guidelines, where we usually, go bink, 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 and then hit amlodipine as the next one. But I think I saw that really the diltiazem and verapamil are better at reducing proteinuria. Do we need to reroute and rethink in those patients in whom we're not achieving the proteinuria reduction that we want? Is there any movement towards that? Are we missing the boat, or did I misinterpret what you had up there?
So, I haven't seen a specific movement towards that, and it's sort of, it gets complicated because hypertension and proteinuria can be interrelated. And so, is it better to really focus on controlling the blood pressure at all costs and then seeing what that does to proteinuria, or is it better to control the proteinuria at all costs and then, sort of try to figure out the blood pressure later? I know that sometimes in patients where their blood pressure, there's a little bit of room to work with the blood pressure, and they're on max dose ACE or ARB, we will put them on we can add the non-dihydropyridines to see if we can get a little bit more, and a little bit greater increase in proteinuria reduction. But again, the benefits of that are all kind of extrapolated, because the paradigm is sort of the lower the better. But, in non-diabetic patients, we're not really sure if that's true. And I think that thinking was what prompted trials like On Target, where they actually combined ACEs and ARBs, and we found out that actually was bad.
So while albumin is the primary protein in the urine, there must be other proteins.
Mm-hmm. Lots of other proteins.
And tell us how those proteins, what those proteins are, and how they differ with different disease states.
So, small proteins like beta-2 microglobulin and proteins like that, those will just get routinely filtered. There are disease states like plasma cell dyscrasias, where you get production of enormous amounts of light chains, and those some of those will actually deposit in the glomerulus, and a lot of those will actually get filtered through the kidney, and so it's important when you're getting a urinalysis on somebody to not just think about albumin, or to remember that the UA really only does measure albumin. And so what I like to do is I always like to confirm the UA with a spot urine protein to creatinine, which will measure all the proteins, just to make sure that I'm not missing other proteins like light chains or something else that might be filtered through, which is not going to be picked up on the UA. The significant proteins in terms of missing some disease process would be looking for light chains, which when they're produced in excess, like in plasma cell dyscrasias or multiple myeloma, definitely get significantly filtered through the glomerulus.
Other questions? Oh.
Thank you. Significant proteinuria and lipoprotein metabolism. There's a link and major adverse effects on lipids. How is that mediated? What is the link between those two processes?
So I don't know. I don't know what the link is. I know that if you have significant lipidation of albumin, for instance, that encourages podocytes to actually take up a lot more of the albumin. So lipidated albumin is taken up a lot more than non-lipidated albumin, and that actually leads to podocyte death and dysfunction, at least in animal models. I also know that if you induce a lot of albumin trafficking or protein trafficking in podocytes, that the podocytes can actually accumulate lipid droplets. But what the exact mechanisms are, I don't know.
I mean, in nephrotic syndrome, for example, the dramatic increase in LDL cholesterol, that must be mediated somehow. Is something being lost in the urine that somehow has a dampening effect on?
So the increase in LDL is thought to be mediated by the fact that when you're nephrotic, your serum albumin drops and your liver tries to compensate by producing excess albumin, and that actually also ramps up LDL production. Your
liver tries? I'm being silly, but that's really what I'm asking. How does the liver try? How is that mediated?
No, it's when serum albumin falls, there's a stimulation of the osmoreceptors in the liver to the low osmolarity from the drop in the albumin. It's thought that is the initiating mechanism that leads to an increase in protein synthesis by the liver, which includes lipoproteins, fibrinogen, coagulation proteins, and albumin.
Okay, well, thank you very much, Judy. This was a great talk.
Thank you.
Appreciate it.